Question number 11. Reason for adding longer acting beta 2 agonist with ICS, inhalable corticosteroid is dash. Options are ICS increases duration action of LABA, ICS increases sensitivity of beta receptor, LABA increases effectiveness of ICS, ICS decreases ADR of LABA. The right answer for the question is option B. Inhalational corticosteroid increases the sensitivity of beta receptor, thereby preventing beta agonism tolerance. Okay, remember one important question. Inhalational corticosteroid. Generally, corticosteroids are anti-inflammatory agent. The mechanism action is they inhibiting phospholipase A2. By inhibiting phospholipase A2 enzyme, inhibiting production of inflammatory mediator, thereby useful to control airway inflammation. Other than anti-inflammatory action, one of the beautiful point of ICS is inhalational corticosteroid increases responsiveness of beta receptor. That means increases sensitivity of beta receptor. That's why LABA given along with ICS. Remember, longer acting beta 2 agonists like salmeterol, formoterol, when you give daily, chronically, chronic exposure to beta 2 receptor causes down regulation of beta 2 receptor. Thereby, these drugs may develop tolerance. To avoid this complication, we give LABA along with inhalable corticosteroid. Remember, corticosteroid increases sensitivity of beta receptor. Very important point. That finishes question number 11. Question number 12. Find out the false statement regarding bedaquiline. Options are inhibiting mycobacterial ATP synthase. It develops resistance due to efflux from the bacilli. Food interfere absorption of bedaquiline. Excretion mainly through feces. Question is, find out the false statement regarding bedaquiline. The right answer for the question is option C. Food interfere absorption of bedaquiline is a false statement. Now we will explain one by one. Bedaquiline, a newer drug useful for treatment of XMDR TB, that is extremely multi-drug resistant tuberculosis. And the mechanism of action of bedaquiline, it is acting by inhibiting mycobacterial ATP synthase. And bedaquiline may develop resistance due to point mutation as well as efflux pump mutation. Food generally increases absorption of bedaquiline, especially fatty meal will increases absorption of bedaquiline. Bedaquiline may show cross resistance with clofazimine. Clofazimine, a drug useful for treatment of leprosy. So bedaquiline may show cross resistance with clofazimine. And coming to adverse effect, it most commonly causing GI toxicity and also causing arthralgia, liver damage, and also risk of causing QT prolongation. Now, other than bedaquiline, you should know some other newer drug useful for XMDR TB. That includes delamanid, britomanid. These drugs are acting by inhibiting mycolic acid synthesis, and they may also cause QT prolongation side effect. And we have some more drug useful for MDR TB. For example, jutizolide and one more drug TED, tedizolide. Both are derivative of linezolid useful for MDR TB. So newer drug for MDR TB is very important. That too, bedaquiline very important. Please revise yourself. Question number 13. Which of the following antibiotic acts on 50S ribosome and inhibits transpeptidase, thereby inhibiting protein synthesis? Option given are neomycin, chloramphenicol, azithromycin and piperacillin. So question is, a antibiotic acting on 50S ribosome inhibiting transpeptidase, thereby inhibiting protein synthesis. The right answer to the question is option B, chloramphenicol. Now I will explain the mechanism action of antibiotic acting by inhibiting protein synthesis. Look here. Neomycin, a aminoglycoside, chloramphenicol, azithromycin, a macrolide. These three group of drugs are acting by inhibiting protein synthesis, whereas piperacillin, a beta-lactam antibiotic, acting by inhibiting cell wall synthesis. Now I am going to explain antibiotic acting by inhibiting protein synthesis. Understanding antibiotic inhibiting protein synthesis, first you should know how a bacteria producing protein synthesis, and then we are going for discussion of antibiotic inhibiting protein synthesis. For that, look at the image. Imagine it is a 30S ribosome and it is a 50S ribosome. The 30S and 50S ribosomes are very important for bacterial protein synthesis. Now, before going to the topic proper, first look at the morphology in this picture. I put here mRNA, that means messenger RNA, and I put here tRNA, transfer RNA, and then the one thing called A site. A site means acceptor site. That is, whatever newer amino acid coming to the bacteria, that newer amino acid will be accepted only at the A site. Then I put one thing P. P means nascent peptide chain, already existing peptide chain. For example, in this bacteria already A1, A2, A3. A stands for amino acid. Already 3 amino acid containing peptide chain is existing. The existing peptide chain will be seen at the P site. It is a morphology. Now for discussion, just for discussion purpose, for teaching purpose, just imagine this bacteria want to prepare a protein which is made up of 5 amino acids. Just for imagination, it want to prepare a protein made up of 5 amino acids. It is for example. This bacteria already having 3 amino acids. It needs 2 more amino acids to complete the protein synthesis. How they going to get the 2 more and how they going to complete the protein synthesis, I am going to discuss. Simultaneously, I am going to discuss antibiotic inhibiting protein synthesis also. So first step, the first step involved in protein synthesis, signaling by the mRNA. We call signaling. While signaling given, the bacteria starts initiation complex and polysome formation. The first step involved in protein synthesis is signaling by the mRNA and formation of initiation complex and polysome. This step is arrested by one group of drug called aminoglycoside. So mechanism action. Aminoglycoside binding with 30S ribosome and causing misreading of mRNA, thereby inhibiting initiation complex formation and inhibiting polysome formation. That's the mechanism action of aminoglycoside. Coming to second point, I told for imagination this bacteria want to prepare a 5 amino acid. It has already 3, 2 more needed. How they going to get the 2 more? Look here. With the help of tRNA, one new amino acid called A4 will be coming to bacteria. Whenever a newer amino acid comes to bacteria, that will be attached only at the acceptor site. So the second step is attachment of new amino acid at the acceptor site with the help of tRNA. So the second step is attachment of newer amino acid at the A site with the help of tRNA. This step is blocked by one drug called tetracycline. Tetracycline is a group of drug acting on 30S ribosome and inhibit attachment of new amino acid at the acceptor site. That is second point. Coming to third point. Okay. Imagine whenever a new amino acid comes, there will accept at the A site. Now the third step is, look at about the already existing peptide chain now moving from P to A. When the already existing chain moves from P to A, the chain length become increased. It is called elongation of peptide chain. The elongation of peptide chain is done by help of one enzyme called peptidyl transferase. So third step is, with the help of peptidyl transferase enzyme, the already existing peptide chain transfer from P to A, thereby the chain become increase in length. It is called elongation of peptide chain. This step is blocked by a drug called chloramphenicol. Remember, chloramphenicol binding with 50S ribosome and inhibiting peptidyl transferase enzyme, thereby inhibiting elongation of peptide chain. Now coming to final step. Look, this bacteria now having 4 amino acid. I told it want to produce 5 amino acid containing protein. So to receive one more new amino acid, the A site should empty. Only at the A site new amino acid will becomes and attached. So to receive the new amino acid, the A site should become empty. To make emptiness, what happened? This peptide chain now getting translocated from A to P, thereby A become free for receiving new amino acid. So the final step is translocation of elongated peptide chain from A to P and making A as empty site to receive new amino acid. This step is arrested by some group of drug called macrolide antibiotic, lincosamide, the so-called clindamycin, and one more drug, streptogramine. So remember, macrolide group of drug like azithromycin, erythromycin, roxithromycin, and then lincosamide, clindamycin, and then streptogramine. All these drugs are acting on 50S ribosome and inhibiting translocation of elongated peptide chain from A to P, thereby preventing protein synthesis. Finally, one more important drug inhibiting protein synthesis, name is called LINE, linezolid. Linezolid acting on 50S ribosome and inhibit initiation complex formation. Action is similar to aminoglycoside, but the binding site is 50S ribosome. Remember, linezolid binding with the 50S ribosome and inhibit initiation complex formation. So ultimate take home message is, remember, protein synthesis inhibitors. First two drugs, aminoglycoside and tetracycline, these two group of drug acting on 30S ribosome. Remaining drug, that is chloramphenicol, macrolide group of drug, then lincosamide, streptogramine, linezolid. All these drugs are acting on 50S ribosome. That finishes some important antibiotic acting by inhibiting protein synthesis. Question number 14. Chloroquine is not recommended for treating individual with all of the following except. Options are myasthenia gravis, psoriasis, amoebiasis, porphyria. Straight question, easy question. The right answer of the question is option number C, amoebiasis. Remember, chloroquine having skeletal muscle relaxing property, so aggravate myasthenia gravis problem. And chloroquine also causes exacerbation of symptom of psoriasis and porphyria, so they are not good in this patient. Whereas you should know uses of chloroquine. We know chloroquine is a drug for malaria. Other than malaria, it is useful for so many conditions. For that, remember simple mnemonic red lip Mahatma Gandhi, where R stands for rheumatoid arthritis, A mean extraintestinal amiasis, D for discoid lupus erythematosus, L for type 2 lepra reaction. Type 2 lepra reaction is called ENL, erythema nodosum leprosum. And also, I mean infectious mononucleosis, P for some photogenic reaction, M mean malaria, G mean giardiasis. So lot and lot of uses are there with chloroquine. Now question number 15. Venetoclax is a dash. Options are histone deacetylase inhibitor, B-cell lymphoma 2 protein inhibitor, phosphoinositide 3 kinase inhibitor, anaplastic lymphoma kinase inhibitor. The right answer to the question is option B, B-cell lymphoma 2 protein inhibitor. Now we are going to discuss all the four options in detail. Next is B-cell lymphoma 2 protein inhibitor, simply called BCL2 protein inhibitor. First, we should know drug name. The example for this category drug is venetoclax. What is the mechanism action of venetoclax? Venetoclax blocks the anti-apoptotic B-cell lymphoma 2 protein, thereby leading to programmed cell death of CLL cells. So, the venetoclax is a newer drug useful for treatment of CLL. It is called BCL2 protein inhibitor. Another one more, and then we have one more small molecule inhibitor group called histone deacetylase inhibitor, called HDA. Histone deacetylase, called HDA inhibitor. The drug names are orinostat and romidepsin. The orinostat romidepsins are histone deacetylase inhibitor useful for treatment of cutaneous T-cell lymphoma. Cutaneous T-cell lymphoma, also called mycosis fungoidosis, also called as Sézary syndrome. That means find out the histone deacetylase inhibitor useful for treating cutaneous T-cell lymphoma. Think of orinostat and romidepsin. Another latest histone deacetylase inhibitor name is panobinostat. The panobinostat useful for treatment of multiple myeloma. So question, find out the histone deacetylase inhibitor useful for treating multiple myeloma. Think of panobinostat. And then we have one latest drug called BELI, belinostat. It is also a histone deacetylase inhibitor useful for treatment of peripheral T-cell lymphoma. Drug name is belinostat. Next, phosphoinositide 3 kinase inhibitor, simply called PI3K. PI, that is phosphoinositide 3 kinase inhibitor. These drug name and all ending with a suffix SIB, ZIB. For example, IDEL, idilalizib, DUVLI, duvilizib, and COPAN, copanlizib. All these drugs names ending with a suffix called SIB. They call PI3 kinase inhibitor useful for treatment of CLL, non-Hodgkin's lymphoma, and also useful for small lymphocytic lymphoma. Hi. In this video, we are going to discuss small molecule inhibitors. In that first, we are going to discuss anaplastic lymphoma kinase inhibitors. These are a newer group of drugs useful for treatment of non-small cell lung cancer. There are three generations of anaplastic lymphoma kinase inhibitors we having. The first generation drug name is CRIZO, crizotinib. Second generation drugs are ceritinib, brigatinib, alectinib. And the third generation anaplastic lymphoma kinase inhibitor name is lorlatinib. All these drugs are useful for treatment of non-small cell lung cancer. Question number 16. Which one of the following monoclonal antibody useful in treatment of malignant ascities? The options given are catumoximab, ramucirumab, belimumab, fremanezumab. The right answer for the question is option number A, catumoximab. It's a very latest monoclonal antibody targeting against epithelial cell adhesion molecule, simply called EPCAM, epithelial cell adhesion molecule, and also targeting against CD3, useful for treatment of malignant ascites. Then ramucirumab, a monoclonal antibody targeting against VGFR, vascular growth factor receptor, useful for treatment of gastric cancer. Useful for treatment of gastric cancer. Belimumab, an antibody targeting against B lymphocyte, useful for treatment of SLE. Then fremanezumab, a monoclonal antibody targeting against CGRP. CGRP means calcitonin gene related protein. So fremanezumab, a CGRP antagonist, useful for migraine. Here important question. Other CGRP antagonist useful for migraine includes we having erinumab and galcanezumab. All are useful for migraine. CGRP, calcitonin gene related protein antagonist. Drug names of fremanezumab, erinumab, galcanezumab. Question number 17. Which one of the following drug has no role in the treatment of multiple sclerosis? The options given are teriflunomide, natalizumab, interferon alpha, fingolimod. The answer for the question is option number C, interferon alpha. It is not useful for MS. Interferon alpha useful for treatment of hepatitis B virus infection and hepatitis C virus infection, whereas interferon gamma useful for treatment of chronic granulomatous disease. So remember, interferon alpha means antiviral, not for MS. So what are the drugs useful for treatment of MS? MS means multiple sclerosis. That we are going to discuss now. So remember, drugs useful for treatment of multiple sclerosis includes interferon beta. Remember important question. Which is the interferon useful for treatment of MS mean interferon beta. Next is glatiramir acetate, a immunomodulator, glatiramir acetate. And very important, there are some monoclonal antibody approved for treatment of MS. What are they? Natalizumab, acrelizumab, alemtuzumab. Here, natalizumab targeting against alpha 4 beta 1 integrin given intravenously once in a month. Maximum 1 year, at the most maximally 1.5 years, that is up to 18 months, because more than 18 months, if we keep on give natalizumab, there's a high risk of progressive multifocal leukoencephalopathy. So one of the dangerous adverse effect of natalizumab, risk of PML. PML means progressive multifocal leukoencephalopathy. Another MAB, acrelizumab targeting against CD20, alentosumab targeting against CD52. So remember, these are three important MAB useful for MS. And then tecfidera immunosuppressant, mitoxantrone, actually an antibiotic anti-cancer drug. This drug may cause cardiac side effect. Fingolimod, a immunomodulator, orally given drug useful for MS. This drug also causing cardiac problem like bradycardia. And then dalfambaradine, a orally given drug, very important. The dalfambaradine in MS patient useful to improve walking capacity. The purpose of using dalfambaradine in MS patient is to improve walking capacity. Next is cladribine. Cladribine, anti-cancer drug useful for MS patient. Then teriflunomide. It's a derivative of leflunomide useful for MS. And one more drug, dimethyl fumarate. It's a immunosuppressant useful for MS. So you should know what are all the important drugs useful for treatment of multiple sclerosis. That finishes this question. Question number 18. Which of the following statement is characteristic of metformin? The option given are metformin containing a boxed warning due to the potential of increased risk of myocardial infarction. Metformin decreases hepatic glucose production. Metformin can be used safely in patients with renal dysfunction. Weight gain is a common adverse effect of metformin. The question is, which of the following statement is characteristic of metformin? The right answer for the question is option B. Metformin decreases hepatic glucose production. So to answer this question, now we go for detailed discussion of metformin, a biguanide. So we are going to discuss in detail about biguanides in the management of diabetes. Okay, the next group of drug what we are going to discuss is biguanides. Example for biguanides are metformin, penformin, buformin. But among the three drugs, the penformin, buformin causes severe lactic acidosis. So these two drugs were withdrawn from market. That means the one and only available biguanide in the market is metformin. So biguanide mean metformin. So now we are going to discuss first mechanism action of metformin. Remember, it's a very important slide. Listen sincerely. Metformin mechanism action is it is activating AMP activated protein kinase. By activating the AMP activated protein kinase, it causes the most important action in the liver, suppresses gluconeogenesis, thereby reducing glucose output. So the most important mechanism action of biguanide is suppressing glucose output from the liver. It's a main mechanism action. There are some other mechanism action also. For example, metformin sensitizes the insulin action in the peripheries like adipose tissue and in muscle tissue. By sensitizing the insulin receptor, it causes increasing glucose utilization in the peripheral tissue. So the peripherally running glucose are utilized properly by the adipose tissue and muscle tissue. That is second mechanism action. And third, a minor mechanism action, metformin also inhibiting intestinal absorption of glucose. By these three mechanisms, metformin controlling blood sugar. Among the three mechanisms, action on the liver, it is the main mechanism action, very important. But when you look at the discussion, metformin mainly acting on liver and then adipose tissue, muscle tissue, and also on intestine. It does not acting on pancreatic beta cell. That means this drug not acting by releasing insulin. That means this drug do not causes hypoglycemia. Very important. It is not causing insulin release, so it is not causing hypoglycemia. So you should call metformin as a orally given anti-diabetic drug. It is not the OHA. OHA means oral hypoglycemic agent. It is not causing hypoglycemia. It just controls only the blood sugar. It's called oral anti-diabetic agent. So that finishes mechanism action. Now coming to the most important part, metformin, the first line drug for type 2 diabetes. And that too in a obese patient with type 2 diabetes means the first line drug of choice is metformin. Actually, in clinical practice, metformin causes mild reduction of body weight. But recent research work shows metformin on weight is weight neutral. That means it is neither increase weight gain nor decrease weight gain. It's called weight neutral, but practically speaking, it may cause mild reduction of body weight, but definitely it will not cause weight gain. Anyway, according to latest Goodman-Gilman book, they say metformin comes under weight neutral category. Yeah, another important point, metformin reduces both micro and macrovascular complications of diabetes. That's a very big important property. And one more point, in a people with impaired glucose tolerance, that is impending diabetes, impaired glucose tolerance in this patient, to delay the progression of diabetes, prophylactically we can put them on metformin. That's also another advantage. So we know the property. Another very important point, metformin sensitizing the peripherally insulin receptor. Because of this action, it is very much useful in PCOD. In polycystic ovary, look at ovary, there's a lot of cysts. All these are cysts. In polycystic ovary, there is a huge insulin resistance resulting in infertility. So, in PCOD female, to improve ovulation, to improve fertility, and to reduce hirsutism complication, we can very well recommend metformin. So that's also one important use of metformin. Now, after finishing property, look at the kinetic. Metformin is excreted through kidney in unchanged form. Very important. Excreted through kidney in unchanged form. That means metformin totally depend upon kidney for excretion. So metformin absolutely contraindicated in kidney failure. But look at the point. If the GFR is more than 45 ml per minute, we can safely give. If the GFR less than 45, definitely metformin need dosage reduction. So, anti-diabetic drug that is definitely unsafe in kidney failure, think of metformin. And one more point, metformin undergo renal route excretion. So, when you do some angiogram or urogram, that means when you do a contrast mediated investigation, radio contrast drugs also goes to the kidney. So when you do radio contrast study in a metformin therapy patient, there's a more risk of nephrotoxicity. So what Harrison book says, in a patient who is a metformin therapy, if they want to go for radio contrast study, better avoid metformin one day before and one day after the procedure. This point practically most important point. After finishing the kinetic, coming to ADR. The most commonest adverse effect of metformin is GI toxicity. It is the most common. So remember, the most commonest problem of metformin GI toxicity in the form of nausea, indigestion, sometimes causing diarrhea, and chronic metformin therapy causing vitamin B12 deficiency. This is also very important, very important. So question, which is the anti-diabetic drug causes vitamin B12 deficiency? Mean, think of metformin. And finally, one more point, there are some situations may precipitate lactic acidosis. So question, lactic acidosis, one of the rare complications of metformin. This will be precipitated in some condition like kidney failure or liver failure or cardiorespiratory insufficiency or in a chronic alcoholic patient. This point is very important. The question is, what are all the factors which may precipitate lactic acidosis with metformin? Think of kidney failure, liver failure, cardiorespiratory failure, and in chronic alcoholism. Definitions metformin side effects. Question number 19. Which one of the following is the glucocorticoid receptor blocker useful in Cushing syndrome? Options are Pessariotide, Mifepristone, Metarapone, Mitotane. The right answer for the question is option B, Mifepristone. Mifepristone actually progesterone antagonist, also having glucocorticoid receptor blocking property useful for Cushing syndrome. The remaining drugs are inhibiting glucocorticoid synthesis, whereas mifepristone inhibiting glucocorticoid receptor. So in general, what are important drugs useful for managing Cushing syndrome? Look here, for the treatment of Cushing syndrome, we have a lot of drugs like metarapone. It's a 11 beta hydroxylase inhibitor. Then we have ketoconazole, an antifungal drug. Then mitotane, aminoglutathione. Remember, these two drugs can be called as chemical adrenalectomy agent. Mitotane and aminoglutathione are called as chemical adrenalectomy agent. Then we have trilostane, Pessariotide, very important. Pessariotide, a stomatostatin analog useful for Cushing syndrome. And then we have one more drug, etomidate. It's a general anesthetic agent having role in the treatment of Cushing syndrome. The finishes important drug useful for treatment of Cushing syndrome. The next, which one of the following drug is the VEGFR antagonist useful in the treatment of wet macular degeneration given intravenously? So 3 points you should note. They are asking which is the VEGFR antagonist useful for wet macular degeneration given intravenously. Options are bevacizumab, ranibizumab, pegabtanib, and verteporfin. The right answer for the question is option D, verteporfin. So now I go for explanation. Look here. Wet macular degeneration is due to overvascularity, excessive vascular supply. So to control this, we need VEGFR antagonist, vascular growth factor antagonist. There are two important groups. One is given intravenously, others are given intravitreally. So question, a drug given intravenously as a VEGFR blocker for treating age-related macular degeneration is verteporfin. Whereas there are so many VEGFR blocker given intravitreally. So what are the intravitreous injection available as a VEGFR blocker? That includes bevacizumab, ranibizumab, pegabtanib, and aflibercept. All these are VEGFR blocker given intravitreal injection for the management of wet macular degeneration.